My name is Ryan Barker. I am the Vice President of Health Policy at the Missouri Foundation for Health. Tonight we are here to talk about Medicaid, the Medicaid expansion decision that is being discussed and debated right now in Jefferson City. But I wanted to start out with a little bit of background on the Missouri Foundation for Health. I don't know if everybody's aware of who we are and what is that organization all about. So the Missouri Foundation for Health is a nonprofit private foundation. Most of what we do is grant making. So we give out grants to community organizations to provide health services for low-income, vulnerable Missourians across the state. We serve 84 counties in the city of St. Louis. Where do we come from? Do we fundraise? Where do we get this money? So we actually are what is called a conversion foundation, which means conversion foundations happen to all across the country, mostly in the late 90s. And what it was hospital systems or insurance companies, health insurance companies. Many of them used to be nonprofit, and then they converted and became for-profit. And when they make that conversion from nonprofit to for-profit, whatever assets they collected as a nonprofit, they can't take with them to the for-profit. So those assets actually spin off from that company and go to create, and what mostly around the country, what happened was they went and created health conversion foundations. So that's what we are. Our assets come from the conversion of Blue Cross Blue Shield of Eastern Missouri. We are not associated with that health insurance company at all. We are our own private entity. Our endowment is about $1 billion, which sounds like a whole lot of money. So we are required to give out 5% a year in community grants. We've averaged closer to 6% over the last 10 years. We have given out since 2002 about $480 million, and our endowment is still right about at $1 billion. $1 billion sounds like a whole lot. Even when I say that, sometimes I'm still like, $1 billion. But if you think about the cost of health care in the state of Missouri, how much do we spend on health care every year? In Missouri, we spend about $30 billion a year on health care. That's private insurance, that's Medicaid, that's Medicare, that's the premiums that you pay, that's your co-pays, your over-the-counter medicines, prescription drugs. If you add all of that up, it's close to $30 billion. So when you think about that, $1 billion is just sort of a drop in the bucket, and we could give it all away very quickly. Most of what we do is fund grants in areas like women's health, primary care, mental health, tobacco prevention, a whole variety of different areas. Childhood obesity is an area we're currently focusing on, oral health. But very early on, our board of directors said, no, we can give away all our money really quickly, and it's just a drop. It's just putting a Band-Aid on this healthcare system. And they really decided that we needed to also focus on healthcare system issues and how do we impact the healthcare system and make improvements at a policy level. So they created a policy area of the foundation, which I am now blessed to be the leader of, and have a wonderful staff that I work with. Now, we do not lobby, so it is in our bylaws that we will not lobby. So we can't take a stand on a specific piece of legislation. But we do a lot of work with policymakers, we do a lot of work in the community, so what are we doing? Well, we actually provide nonpartisan, fact-based information. We do that to both policymakers and then in settings like this. We've been traveling the state. This is my 7th forum on Medicaid expansion. But we actually have been doing the same thing related to the broader issue of the Affordable Care Act for the past 3 years. And just love it or hate it, we need to all understand what is this law and what does it mean for us. So tonight we are specifically going to talk about Medicaid and what was in the original ACA and how that changed because of the Supreme Court ruling. But I want to start with recognizing that all of us come from a different place in understanding what is Medicaid. So I want to start with a little bit of basics about what is the Medicaid program. So people often get confused between Medicaid and Medicare. They both were actually created at the same time. They were created in 1965. Medicare is a national program run by the federal government that provides health insurance for mostly seniors, but also certain people with disabilities. Medicaid is also a public health insurance program, but it's targeted specifically at certain groups of low-income individuals. There is a certain set of federal rules that apply to Medicaid programs, but largely Medicaid programs are administered at a state level. So a state has a lot of control over what their Medicaid program looks like. So every state, we really have 50 different Medicaid programs in this country. So Missouri has sort of its own rules and eligibility and enrollment procedures that are very different than other states. Today, Medicaid covers about 58 million Americans. In Missouri, it's about 900,000 Missourians right now. So total population of the US is 310 million, so 58 million out of 310. We're at about 1 in 6. In Missouri, it's 900,000 out of 6 million. So we're also a little bit, we're between 1 in 6 and 1 in 7 Missourians that currently receive Medicaid. Medicaid is paid for through a combination of federal dollars that come to the state and then state funds. And right now it's about 60% federal dollars and 40% state dollars. Originally and really to this day, the Medicaid program, a lot of people think, well, Medicaid covers everybody that's low income. And that's actually not true. There are certain groups of low-income individuals that are eligible for Medicaid program. And it really is tied back to 1965 and the law that was passed. It was focused on the welfare population and providing health insurance for those that were eligible for welfare. And welfare was really targeted at single parents with dependent children and then individuals who were very low income that were, it's not very politically correct, but the individuals who were age blind or disabled. I call my father aged, and he doesn't think that's funny. And that really hasn't changed much. So that is still specifically the population, for the most part, that most states cover in their Medicaid programs. So let's talk a little bit about what does Medicaid currently look like in Missouri. So like I said, eligibility is different state by state. So if you cross over the bridge into Illinois, their Medicaid program and eligibility levels are completely different than ours. In Missouri, we are actually one of the top 5 most generous states in the country when it comes to covering kids with Medicaid. So we actually are very generous with kids. We cover kids and families up to 300% of poverty. And if you don't understand what 300% of poverty means, my next slide will explain that, so hang on. Now this kids coverage, this really tall blue bar, actually is a Medicaid program and a CHIP program. And if you've ever heard of CHIP or S-CHIP, it stands for State Children's Health Insurance Program. Some states have 2 separate programs. Missouri combined them into one program, which is why this is just one tall, big blue bar. On the exact flip side, this next eligibility category is parents. Missouri is one of the bottom 3 states for eligibility for parents. We changed that in 2005. So currently it's at about 18% of poverty. Let me give you an example. So if we have a single mom with 2 kids, so a family of 3, for that mom to be eligible for Medicaid in Missouri, she has to make less than $3,500 per year. And that's per year. So if she makes more than $3,500, she is not Medicaid eligible. Pregnant women, we cover up to 185% of poverty. The federal minimum is 133, so we're slightly above the federal minimum. Individuals who are blind, we cover up to the poverty level. So if you hear poverty level, poverty line, 100% of poverty, those are all the same thing. And we'll talk about what that means in a second. And then individuals who are either over age 65 or disabled, we cover up to 85% of poverty. Now I keep saying poverty line, poverty level, what does that mean? Every year the federal government, Health and Human Services, comes out with what is the federal poverty level. It is exactly the same, and it's sort of controversial, but it's exactly the same for the lower 48 states. Hawaii and Alaska have their own poverty levels. So if you hear that poverty line, that 100% of poverty, you can see that it's different based on family size. So a family of 3 at the poverty line is making about $19,500. So you can see the eligibility categories. I had them broken out. So 85% of poverty is that elderly and disabled population, 100% is individuals who are blind, 185 is pregnant women, and then 300% is kids. Now, parents aren't up there. Why? The federal minimum for parents is actually not tied to the poverty level. It's the only category that is sort of separate and a little bit wacky. The minimum that you can have for covering parents is tied to the income levels from 1996 from Missouri's income standard for the AFDC program. AFDC stands for Aid for Families with Dependent Children. It was our welfare program. It doesn't exist anymore. It is now TANF, Temporary Assistance for Needy Families. But in 1996, these dollar amounts were the income levels to be eligible for welfare. And that's the federal minimum, and that's what Missouri reduced ours to. So those dollar amounts haven't changed since 2005. They don't get adjusted with the poverty level. So every year, parental eligibility actually becomes a smaller percentage of the poverty level. So I want to start with the Supreme Court case. So last summer, the Supreme Court made a ruling on the Affordable Care Act, or Obamacare, or the Patient Protection and Affordable Care Act. It's all the same thing, health reform. The ACA, the Affordable Care Act, passed in March of 2010, and almost immediately 26 states sued the federal government. And they didn't sue necessarily about the whole law. There were certain components. And the big one that everybody was paying attention to was that the Affordable Care Act says every American has to purchase health insurance. And it's called the individual mandate. And it's mandating that you have health insurance, and if you don't, you have to pay a fine. So everybody was sort of paying attention to that part of the Supreme Court case. And last June, late June, June 28th, the Supreme Court made their ruling, and by a 5-4 decision, it was a close decision, but by a 5-4 decision, they did decide that an individual mandate was constitutional, that Congress was within its authority under the Constitution to do that. The question that they also reviewed that a lot of people just didn't even, unless you work in sort of social services or healthcare and know about Medicaid, a lot of people weren't even paying attention to this. They actually ruled on the Medicaid expansion. So originally what the Affordable Care Act said was every state will expand its Medicaid program. It wasn't optional. They said you will, and if you don't, you actually lose all of your funding for your existing Medicaid program. So the penalty was really harsh, and that's what the states sued about. They said, this is way too coercive, you're not giving us enough time or enough voice in the decision-making process, and the Supreme Court agreed with them. And they said that Congress can expand Medicaid, but they can't force states to do that. They can't take away all of the existing money in order to force them to expand. So what did this really do? What that Supreme Court ruling means is that every state legislature gets to decide for themselves whether to expand Medicaid. So currently in Missouri, we are currently in our legislative session. It runs from early January to mid-May. We are talking, there are bills that have been filed in both the House and the Senate related to this Medicaid expansion. The foundation feels that it's important, whether you agree with Medicaid expansion or you're against it, that you understand what is being debated in Jeff City and that you let your voice be heard. So regardless of whether you want to call and say, yes, vote for this, or no, don't for this, we encourage you to call your legislators and let them know how you feel. So I want to start with a little bit, as we dig into the Medicaid expansion, it's important to sort of frame it within a little bit of a larger component of the Affordable Care Act. Yes, I've read the ACA, I don't recommend it to anybody. It puts you to sleep. But there are major themes of information in the Affordable Care Act. What were they trying to accomplish with the ACA? And one of the major themes that they were trying to work on was the issue of the uninsured. So currently in America, we have about 48 million uninsured Americans. So that's 48 million out of 310 million. So once again, about 1 in 6, 1 in 7 Americans that don't have health insurance. And Congress said, with health reform, we want to get as many of those uninsured to have health insurance. Now that right there is a political ideology sort of conversation. And there was the more conservative side, when they were discussing the Affordable Care Act, was saying we need to get health care costs under control. And the more progressive side was saying we need to expand health insurance to more Americans and then address cost control. And really, the Democrats were looking at the Massachusetts model. So in Massachusetts did a health care reform at the state level in 2005. And their major emphasis in Massachusetts was expanding health insurance to more people that lived in that state. And if you look at, we can look back, and I mean it's been 7 years now, we can look back at Massachusetts, have they been successful? So they have their uninsured rate down to 1.9% of their state's population. So they reduced the number of uninsured. Now, before Massachusetts did health reform, it was the most expensive place in the country to receive health care. 1.9% of their state's population. So they reduced the number of uninsured. Now, before Massachusetts did health reform, it was the most expensive place in the country to receive health care. 1.9% of their state's population. So they reduced the number of uninsured. Now, before Massachusetts did health reform, it was the most expensive place in the country to receive health care. after health reform, it's still the most expensive place in the country to receive health care. But the emphasis of that health reform was on the uninsured. And now Massachusetts legislature is coming back and saying, we need to start addressing costs. And they're actually looking at that currently. So Congress they took the same approach. They said, let's get as many Americans into health insurance. There is some tinkering around with healthcare costs in the Affordable Care Act, but really, and a lot of people don't want to hear that we have to go through this whole health reform thing again. We need to come back, and we need to also start looking at healthcare costs in this country and getting those under control. So the ACA expands health insurance through two main mechanisms, both health insurance exchanges and the Medicaid expansion. And I'm going to briefly talk about health insurance exchanges because it's important to understand how Medicaid expansion and the health insurance exchanges sort of build on top of each other. So if the Medicaid expansion was mandatory and every state did it, the original estimate was that these two new programs would cover 32 million out of that 48 million uninsured. So there would be about 16 million remaining uninsured, and I'm just going to answer the question because I often get asked, who are those 16 million? A large chunk of them, probably somewhere between 10 and 12 million, it's tied to immigration status. Now immediately everybody goes to undocumented immigrants. A big chunk of those are undocumented, but a lot of people don't know, even if you come into this country legally through the normal process to become a citizen, you are not eligible for programs like Medicaid for the first 5 years you're in the country. So a lot of that remaining uninsured will be legal immigrants that are not allowed to have Medicaid. Now there is an exception. If you have refugee status, you can get Medicaid, but most legal immigrants cannot get Medicaid. The remaining uninsured are going to be people who decide, yeah, Congress told me I have to have health insurance, but it's cheaper for me to pay that fine, so I'm just going to pay the fine. And we think it's probably going to be 4 to 7 million Americans that make that decision. So what are these health insurance exchanges? What was the impetus? What is this idea all about? What are they trying to do? Well, really what they're trying to do is address some of the problems with the health insurance markets in this country. So what are the problems? So if we look at large employers, and I'm defining large employers as more than 100 employees. If we look at large employers, health insurance works fairly well for large employers. And how do we know that? Well, one of the ways we know that is that large employers in Missouri, 96% of large employers still offer health insurance to their employees. So when you have a large pool of employees, you're spreading out the health risk among a large pool. It keeps costs relatively stable. That's the way insurance is supposed to work. Think about car insurance or homeowners insurance. Not everybody gets in a car accident every day. You have everybody in a large pool. It spreads out the risk. We start running into issues when we look at small employers, and once again, that's under 100 employees, or people that don't get health insurance at work and are trying to go out and purchase insurance for themselves or their families. Health insurance becomes a little bit more difficult when you're talking about small employers or individuals and families. And why? Well, let's say you have a small employer with 20 employees. We are seeing increases in obesity. Our tobacco rates across the country have sort of stabilized, and we're not seeing a lot of drops in them. We're developing a lot of chronic conditions like high blood pressure and asthma and diabetes and hypertension. Well, when you have 20 employees and 10 of them have some sort of pre-existing condition or some sort of chronic condition, it's going to drive up your healthcare costs really quickly. And so we see that small employers are getting priced out of health insurance. They can't afford to offer it to their employees anymore. And how do we know that? In Missouri, those small employers with less than 100 employees, only 43% currently offer health insurance to their employees. So less than half of the small employers in our state are still able to offer health insurance. Same thing with the individual market. If you are 25 years old and perfectly healthy and you don't get insurance through work and you go out and try to buy your own plan, you can find reasonable health insurance for yourself. The problem is, as you start aging, if you have any sort of pre-existing condition, chronic condition, you are quickly going to get priced out of the insurance market as an individual, or those insurance companies can say, ooh, you've become too high risk. We're not even going to offer you insurance. We're not even going to name a price. We're just going to say no. We're not going to issue you health insurance. So it really is what the health insurance exchanges are trying to address is not the large employers, it's really the small employers and the individuals. How do they do that? So a health insurance exchange is really a marketplace. So just think of it, I often describe it as a farmer's market because people get what that is. You go into a farmer's market, there's farmers, they're in different stalls, they're selling their produce. Replace those farmers with health insurance companies. Replace the produce with health insurance plans. So you now are going into a marketplace of private health insurance. Each stall is its own health insurance company, and they are selling certain health insurance plans to you. Now these plans are supposed to be very similar, easy to compare, easy to price. You're supposed to be able to give those insurance companies very basic information about yourself. The reason exchanges are part of the solution is what it does is when you go in as an individual or you go in as a small business, you're not just going in as a small business. You're going into this pool with all the other small businesses that enter the exchange. So what it does is group everybody together, and it creates these large pools like large employers have. It is giving the same buying power to individuals and families and small businesses that large employers already enjoy. These health insurance exchanges opened January 1, 2014. That's when coverage starts, but enrollment starts October 1st of this year. So we're about 6 months out from enrollment opening. Initially, these exchanges are open to individuals, families, and small businesses with less than 100 employees. Now, if you go into the exchange as an individual or as a family, based on your income, you may get help paying for your monthly premiums in the exchange. And they're called premium subsidies, and it's sort of a sliding scale fee based on your income. And I want to quickly talk about that. So these premium subsidies start at the poverty level. So they start at 100% of poverty. They go all the way up to 400% of poverty, and as you have higher income, the subsidy gets smaller and smaller and smaller. So I'm going to walk you through a couple examples. So let's say this is for a family of 4, and I know it's a little overwhelming. Family of 4, let's say we have a family of 4 at 100% of poverty. That means their income is $23,550. If they go into the exchange, they are responsible for paying 2% of their income towards the purchase of health insurance. So over the course of a year, they have to contribute 2% of their income. Whatever the difference is beyond what they pay, that is made up for in a federal premium subsidy. Now, it's a sliding scale, so as you go up, if we have somebody at 200%, family of 4 is making about $47,000, they have to pay 6.3% of their income towards health insurance. The difference is made up in premium subsidies. This goes all the way up to 400% of poverty. At that level, the families are paying 9.5% of their income, so almost 10% of their income towards health insurance. Subsidies are going to be minimal, if at all. It depends on what type of health insurance plan you choose at that level. So why I talked about health insurance exchanges and these subsidies will become apparent in a minute, but the thing I want to point out is they start at 100%, they go to 400%. Keep that in mind. So Medicaid expansion. What did the law originally say? The Affordable Care Act originally said states will, it wasn't really a choice, will expand Medicaid up to 133% of poverty for all non-Medicare individuals and families. And I'll explain exactly what that means in the next slide. These expanded enrollees, all the new enrollees into Medicaid would have a guaranteed benchmark benefit package. All that means is they would have a standard set of benefits that were sort of the floor. You had to provide at least this basic set of Medicaid benefits to enrollees. For the first 3 years of this Medicaid expansion, the federal government would pay the full cost. So 100% of the cost for 2014, 15, and 16, and then it will step down. So in 2017, the feds pay 95%, the state has to pick up 5%. It steps down by the time we get to 2020, the feds will pay 90% of the cost, the state has to pick up 10%. And right now, the way the law is written, it says from 2020 until infinity, the feds will cover 90% of the cost for these new enrollees, and the states will have to cover 10%. So what did that first bullet, expand Medicaid to 130 for non-Medicare individuals, what does that really mean? So let's look at what it means for Missouri. So the blue bars are the current eligibility that we already talked about. The Medicaid expansion is really focused on 2 main populations. It expands parent eligibility, and in Missouri, it would expand parents from 18% of poverty up to 133% of poverty. Now let me stop right there because some of you, if you've read about this at all, you may see two different numbers out there. You may see it expands Medicaid to 133, it expands Medicaid to 138. They are both correct. Why? The Affordable Care Act, the first line under this section says Medicaid will expand to 133. The second line says, and we will disregard the first 5% of people's income. So technically, it does expand Medicaid up to 138% of poverty because we're ignoring the first 5% of income. So it expands parents from 18 up to 133, and it actually creates a brand new category for childless adults. So currently, if you don't have any dependent children, you're not over age 65, you don't have disability, you aren't disabled, you're not Medicaid eligible, regardless of your income. So in Missouri, about 60% of the homeless are not Medicaid eligible because they're not disabled, they don't have dependent children, they may be making zero or very little money in a year, but they aren't eligible for Medicaid because there's no category in Missouri for childless adults. And there's only about 7 states that even currently cover childless adults at all. So it would create this brand new category of childless adults up to 133% of poverty. Now, you will notice why blind, elderly, and disabled stay where they are. Why? Why did they not expand everybody up to 133? Well, if you'll remember at the very beginning of my presentation, I said what was one of the major themes of the Affordable Care Act? Expanding coverage to as many uninsured as possible. Those 3 groups, what insurance do they currently have? Medicare. So Congress actually said we have limited dollars to work with. Believe it or not, Congress does know they at times have limited dollars to work with. And they were trying to cover as many uninsured as possible. And so they said, let's focus where the most uninsured are, and it's parents and childless adults. So they did not expand the categories of age, blind, or disabled. I wanted to give you a sense of what are we talking about, expanding to 133% of poverty. So currently for a family of 2, that's about $20,600. For a family of 4, it's about $31,000. So anybody in that parent or childless adult category that made less than that amount would be Medicaid eligible now in the state of Missouri. So these are not really high incomes. These are what I would pretty modest incomes. Why did I talk to you about the exchange? Why did I even bring that up? Because love or hate the Affordable Care Act, there was a brilliance to some of what they did in that law. These 2 programs to cover the uninsured built on top of each other. So if you take the categories of parents and childless adults, this little green box at the bottom is current eligibility in Missouri. It's very minimal. And then they built Medicaid expansion on top of that all the way up to 133 or 138. Then they built the exchanges. So Medicaid is public health insurance coverage. Exchanges are private health insurance. And the exchange subsidies to help you afford insurance start at 100% and go up to 400%. So you can see how these 2 programs, even though one's public health insurance, one's private health insurance, they really did build on top of each other. And they purposefully made some overlap between the 2 programs because we know that people's incomes change, they move around on these income brackets, and at that level they wanted people to have a choice. So in Medicaid you usually don't, although we could ask people to pay monthly premiums. There usually are very low copays in Medicaid. So some people may say, I want Medicaid coverage. I'm at 110% of poverty. Other people may say, you know, there are issues with access to providers in Medicaid. I'm willing to pay 2% of my income because I want private insurance. There's stigma around Medicaid. You often have hard time accessing specialists with Medicaid. I want private insurance. So they purposely sort of gave people an option in that dotted area. The issue that we now sort of face because of the Supreme Court ruling is that yellow box on the slide that is Medicaid expansion is now optional. So what does that mean? So if Missouri would not expand Medicaid, that yellow box goes away. And what does that mean? That means that people above 100% of poverty would be eligible for subsidies in the exchange. What about people below 100% of poverty? They can go to the exchange, they can purchase private insurance, but they have to pay full price. There are no subsidies for people under 100% of poverty. And that's because that's the way the law was written, because originally everybody under that level had Medicaid. So we now are creating a situation, if we don't expand Medicaid, it creates sort of this donut hole where we're going to have very basic Medicaid coverage and then nothing. And then once we hit 100% of poverty, people will be eligible for the exchange subsidies. So I want to walk through a little bit of data around Medicaid expansion. What does this mean specifically in Missouri in terms of dollars and enrollment, and what are we talking about? So in Missouri, there have been 4 main research reports, and I'm not going to get into it too heavily, but there have been 4 main reports that have specifically looked at Medicaid expansion in Missouri. And I find, instead of just picking one of them, I thought, you know what, it's better to just give people sort of an idea of the range, because we don't know for sure. But these 4 reports have looked at enrollment. How many people are we talking about? How many people are we expanding Medicaid to? And the range for these 4 studies was in 2014, so starting next year, enrollment would be somewhere around between 160,000 and 260,000 new eligibles for Medicaid. And that by 2021 or 2022, enrollment in the new expansion would be between 160 and 383,000. Now that's a huge range in 2022. And I will tell you, one of the studies you can see, this is the same study that went from 159 to 161 over an 8-year period. That's not enough. They had nobody, sort of everybody enrolled the first year and then very few people enrolled after that. I don't think that's right. I also think this 383 is really high. That was done by a national organization that looked at Missouri, but they don't understand Missouri as well as some of the other people that were doing research. I really think by 2022, we're talking about between 200 and 300,000 people. The state administration, which I want to put out there, the state administration is Governor Nixon's office, so that's where this is coming from. The state administration has estimated that about 260 new enrollees in 2014, and that by 2022, about 308,000 new enrollees. This is from a report, one of those 4 reports that was done by, it was a combination study between Washington University and St. Louis University here in St. Louis, that looked at Medicaid expansion across Missouri by county. And part of their research was estimating county by county what percentage of those county residents will become eligible for Medicaid. The darkest brown is under 6% of those county residents will become eligible for Medicaid. The tan is 6 to 8%. The light blue is 8 to 10%. The darkest blue is above 10% of those county residents will become Medicaid eligible. And you can obviously, sort of, it jumps out at you, that I-70 corridor across the state from St. Louis to Kansas City is where we see the counties that are sort of least impacted percentage-wise. And a Medicaid expansion in Missouri will have the greatest impact in the northern part of the state and then across the southern part of our state. So it really is our most rural counties that have the most to sort of gain from Medicaid expansion in terms of insurance coverage for their county residents. How much are we talking? How much money? So we're going to start with how much federal money, because where does federal money come from? It comes from us. It comes from taxpayers. So federal money isn't free. We pay taxes and then it comes back to the state in different ways. So how much will it cost the federal government to expand Medicaid in Missouri? So once again, it depends on how many people actually enroll. But there are estimates and they are ranges. Starting out in 2014, the range is that somewhere between $900 million and $1.6 billion in federal funds will come to pay for the Medicaid expansion. By 2022, that federal spending is somewhere between 1.2 and 2.3 billion. The state administration, so once again, Governor Nixon's office, has estimated that over this 7-year period, it's about $16 billion in federal funds coming to the state of Missouri. What about the state share? So that was federal funding. How much do we have to pay as a state? Well, you will notice on my slide, 2014, 15, and 16 are missing. That's because the feds are paying 100% of the cost those first 3 years. So starting in 2017, I want to make it clear that with Medicaid, that the state share of Medicaid isn't all general revenue. So general revenue is what we think of as sort of our tax dollars going to the state and paying this general revenue. To pay for Medicaid, there's general revenue, and then there's these other funding sources, and I'll talk about those in a second. In 2017, it's about $30 million in general revenue, about $24 million from these other funding sources. By 2021, it's about $143 million in general revenue, $116 million from other sources. Now those, $150 million is nothing to sneeze at, but keep in mind, compared to the federal $16 billion, it's a pretty small amount that the state would contribute. What is that other funding in Missouri? And I just wanted to give you a sense. I'm not going to go through all of this. This is the Medicaid budget in sort of pie chart form, very simplified. The red is federal dollars. So you can see about 60% of our Medicaid budget in the state is federal dollars. Only about 21% is general revenue. And a good third, a good 30% is this other funding. What is that other funding? So there are these things called provider taxes. So we tax our hospitals, our nursing homes, our ambulances, our pharmacies, and they're called provider taxes. We tax them, that money comes to the state, we use that to help pay for the Medicaid program. There's also quite a bit of tobacco money. So back in I think it was the 90s, we did the master settlement agreement with tobacco companies. There's a lot of tobacco money that we still get paid from those tobacco companies. Missouri we don't really use ours for tobacco prevention or cessation. We use ours to help pay for Medicaid. So a lot of that money goes there. People do pay premiums in Medicaid, and so part of that is people's premiums go to support the Medicaid program. But there's just a whole, and you can ask me if you want to know specifically about one of those, if you can read it on the slides. So the state has also, and I will acknowledge this is the state, so the state administration has said, this is what we have to spend, but if we expand Medicaid, we'll actually save money. Now, why would we save any money? And the state has split that into Medicaid savings and are sort of two categories, Medicaid and state only. And I'm going to quickly sort of explain, so these are in millions, and you can sort of see the savings projected. Why would there be savings? Let's say that we have a parent, a woman, who comes into the Medicaid program in 2020, and she comes in as a parent in this pink bar. So let's say she's at 100% of poverty. We've expanded our Medicaid program. She's eligible for Medicaid. In 2020, the state would be getting that 90-10 match, where the feds are paying 90%, the state is paying 10% for that individual that just entered the program. Let's say in 2022, she becomes pregnant. She actually moves from the pink bar to this category of pregnant women with the blue bar, which remember has a match rate around 60% feds, 40% state. The thing that the state is talking about with this Medicaid category is that when you go in as a parent in this pink bar, that enhanced match rate follows you. So when she became pregnant in 2022, she gets to keep that 90% match rate with her when she moves to the pregnant women category. Now what the state is saying is we probably would have covered her in 2022 as a pregnant woman, and we would have only gotten 60-40, but now because of Medicaid expansion we get 90-10. So that generates savings. So that's how they're coming up with those numbers. The state-only savings comes from, so I sort of lied to you a little bit. There is one other main category of people that are impacted by a Medicaid expansion. And the largest category is what we term the medically frail. So currently Missouri has a program for the medically frail federal dollars. So it is 100% paid for by the state. That medically frail category includes about 17,000 individuals, so it's not a huge number of individuals, but those individuals will now be eligible for Medicaid under the childless adult or parent category. And so we actually are going to be able to shift all of those medically frail into one of the two expansion categories, which will save the state a lot of money. Initially we'll go from 100% state funds to 100% federal funds. It's a pretty small category, and sort of the savings stays very same over time. It jumps from 13 to 27 million, but that's where that savings is coming from the state-only program. This is sort of a summary slide of everything I've talked about. So the top line is cost for the new eligibles, state costs, and it's state general revenue costs. So it's that 30 million in 2017, 143 million in 2021. The next line is those savings that we just talked about. The third line is new revenues. So why would there be new revenues? What do they even mean by that? So if we are getting $16 billion in federal funding, what is that money going to be used for? It's going to come down to the state. It's going to pay for expanded services for all these new Medicaid recipients in hospitals and clinics. So a lot of new healthcare professionals will be making a salary. We'll be hiring new people. We also will be buying durable medical equipment, goods and services within a hospital, healthcare goods. When you purchase things or when you hire people, what do we do to those? We tax them. So if you hire new people, they're paying income tax. If we buy things, we're paying sales tax. So all of that new federal money coming in, a lot of it is getting taxed, which provides new revenues to the state of Missouri. So that third line is new revenues. So what they did was sort of add up those three lines, and the bottom is the total impact on general revenue. And you can see across this bottom from fiscal year 14 to fiscal year 21, what the state is projecting is that there is actually no cost to the state to expand Medicaid, that we actually save money over this time period. In the governor's budget this year, he's estimating about $47 million in savings if we expand Medicaid. Now, it is true, and I want to point out that they purposefully went through 2021 because that's when these bottom numbers stay black. Once you go into 2022, the bottom line is that there will be some impact on general revenue. That number will be red, which means that it'll be a cost and not a savings. But we're talking 8 years out before there's actual cost to the state. So that's sort of background. I'm going to talk about what are the arguments against expanding Medicaid, what are the arguments for expanding the program. I'm going to start with arguments against expansion. So we are down in Jeff City. We don't lobby, but we do talk to legislators, and so we hear what are people talking about down in Jeff City in terms of this Medicaid expansion deal. And there are a lot of people, both politicians, both policymakers, and in the general public that are saying, we are $16 trillion in debt as a country. We spend about $8,000 per person on health care. Compared to the next closest country to us is Switzerland, they spend $4,000 per person and have better health outcomes. Why would we spend all of this new money doing this right now? One, we can't afford it, and one, we need to reform healthcare costs and the way we fund healthcare in this country before we spend all this new money on expanding Medicaid. We had a fiscal cliff deal at the beginning of the year. We are currently under sequestration. There is an argument that we can't afford to do this right now. Now, as a state, you just saw it's not going to cost us a lot as state government, but it's a lot of money coming from the feds, and that's taxpayer dollars coming back. There also is an argument that Medicaid is a broken system. So there is a lot of issues with Medicaid. I think most people will acknowledge that. I think we do a pretty good job of providing primary care for Medicaid recipients. We have a lot of safety net clinics, rural health clinics, FQHCs that provide that type of care. There are issues with Medicaid recipients being able to access specialists. And so some people are saying if there's already issues of access with Medicaid, why would we expand the program? Now, some of those access issues are self-created in the state of Missouri, so every state runs its own Medicaid program. We set how much we reimburse providers for Medicaid services. So Missouri reimburses providers about between 60 and 70 cents on the dollar that Medicare reimburses. So we're pretty low. But we could raise our reimbursement rates for healthcare providers and pay them more, and it would open more providers' doors to taking Medicaid patients. That's also a cost choice. If we raise provider rates, it's going to cost more. Another argument is, so like I said, this deal, this 90% feds, 10% state, from 2020 until infinity, it's Congress. Congress can change its mind at any time. So there could be a bill passed. It's not like we passed Medicare and Medicaid back in 1965 and those programs have never changed. So Congress could change its mind and say, we were really generous, maybe we're going to do 75% feds, 25% state. So there is some concern that Congress could change its mind and all of a sudden Missouri could be on the hook for a lot more money. So its share could increase. The last argument against expansion came out, I think it was about a month ago at this point, and I just wanted to acknowledge it. Moody's is a credit rating agency in the US, and Moody's downgraded Missouri's credit rating. And it did this to several states. It wasn't like we were the only one. Our credit rating in Missouri was downgraded from AAA stable to AAA negative outlook. Now it's still AAA, but why did they do that? Well, they did that, and it has less to do with Missouri and more to do with the federal government. So what they're saying is we're $16 trillion in debt. We're facing, like, every other week it seems like we have some fiscal cliff fiasco going on. People in Congress can't compromise. They can't come together and work on anything. And states are really reliant on federal money. We get a lot of money, every state does, for roads, for bridges, for public education, and for health care. So states are so reliant on the feds for money, and the feds' fiscal house is sort of a mess right now. So because the feds' fiscal house is a mess, it impacts states. So that's really why our credit rating got downgraded. And there is some discussion that, well, if we expand Medicaid, we're just taking more federal money, and does that put us at further risk in terms of our credit rating? So what are the arguments for expanding Medicaid? The first one I call sort of that ethical moral argument of if we don't expand Medicaid, what it does is create that yellow box goes away, and it really creates a donut hole where people have no health insurance options. And there is sort of an ethical moral argument, is that what we want to do as a state, is create a donut hole where people will remain uninsured? The second argument for expansion is reductions in DSH funding. And I have to explain what the heck is DSH funding and what does that mean. So DSH stands for, and this isn't going to help you any, but DSH stands for Disproportionate Share Hospital Payments. What are DSH funds? So we currently have a law, a federal law, that says if you come into the hospital emergency room, they can't ask you your insurance status, and if you're uninsured, they say, oh, go somewhere else. They have to see you, and they have to treat you, and they have to stabilize you. That costs money. They are providing healthcare services mostly to uninsured people who can't afford to pay them. Now, they do try sometimes to charge the uninsured for their bills. They don't get a whole lot of money from that. So where do they get money to actually provide care for the uninsured? Some of that cost they shift onto people with private insurance, but a big chunk of it comes from DSH funds. So DSH funds are funds that come from the federal government, they come to the state, and then they are distributed to hospitals around the state depending on the percentage of uninsured that walk through your doors. The issue is, that's great, so that helps hospitals stay afloat and care for the uninsured. The issue is that when Congress passed the Affordable Care Act, they said, we're going to expand coverage to 32 of the 48 million uninsured. We're only going to have 16 million uninsured left. We sure don't need all those DSH dollars because we're going to reduce the uninsured by so much. So we can use those DSH dollars for other things. So they cut the DSH funding pretty drastically over about a 6-year period. And those DSH funds are going to go to help pay for the Medicaid expansion. The problem with the Supreme Court ruling last summer is it had to do with the individual mandate and it had to do with the Medicaid expansion. The Supreme Court didn't even look at the provision of the Affordable Care Act that had to do with the DSH funding cuts. So guess what? Those DSH funding cuts are they're going to happen. They start January 1st, 2014. In 2014, Missouri is estimated to lose $400 million in DSH funding. The problem is if we don't expand Medicaid, but we still have those DSH cuts come forward, hospitals are going to, what are they going to do? They still have to see the uninsured. They have less funding to pay for that care. So they really are going to have two options. They are either going to pass as much of that off onto people with private insurance as they can, or they're going to go out of business. They cannot stay afloat. So the average Missouri hospital currently has a profit margin of 2.1%. That's not a great it's an okay profit margin, but 2% is not a whole lot. So we have a lot of hospitals that are just sort of hanging on. They're doing okay, but a major hit like this is going to really hurt them. So we've heard I think that urban hospitals will survive. They will find a way to make the funding work. It's going to be tough. It's going to be ugly. They'll do it. As from the foundation perspective, we are most concerned about our rural hospitals. The rural hospitals, a lot of them are barely making it right now. One of my next few slides is Channel 9 here in St. Louis did a special on the Medicaid expansion and showed both sides of the issue, and they actually interviewed the CEO for Salem Memorial Hospital in Salem, Missouri, and pretty much on camera he said if these DSH funding cuts continue and we don't expand Medicaid, Salem Memorial may close. So I don't think we really want a state where biggest tourist attraction is probably Lake of the Ozarks without Lake Regional Hospital, the only hospital at Lake of the Ozarks. But it is a possibility that if these DSH cuts happen and we don't expand Medicaid, it could get very ugly for Missouri hospitals. I already talked about that savings to state general revenue. I talked about the income and sales tax. If there was a report, one of those 4 reports was done by Mizzou, University of Missouri Columbia, and it focused more on the economics of the Medicaid expansion. It estimated that all that new federal money would create about 24,000 new jobs in the state of Missouri. And then the final argument for expansion has to do with employers. And you may have noticed if you're reading on Medicaid, and it seems to be in the news every day lately, a lot of chambers of commerce around the state have come out in favor of Medicaid expansion. So just today or yesterday, my days are blurring together, the Cape Girardeau Chamber of Commerce came out in favor. Springfield Chamber of Commerce, St. Louis, Kansas City, Columbia, Kirksville, and the state Missouri Chamber of Commerce has come out in favor of Medicaid expansion. Why? 2 reasons, and one we've already talked about. They are worried about this cost shift. If we don't expand Medicaid and we lose a lot of those DSH funds, the hospitals are going to have to shift costs onto private insurance. That impacts employers. So the chambers are worried about that cost shift increasing. The other thing is and I'm not going to get into the weeds on this one, but there are some things in the Affordable Care Act that impact employers in terms of if you have more than 50 employees, you have to offer insurance or pay a fine, and you have to offer affordable insurance or pay a fine. What the chambers are looking at is that affordable insurance for for employers with more than 50 employees. Why are they looking at that affordable insurance clause of this? Because if you have employees that are hourly wage employees, lower income, hourly wage, if they're Medicaid eligible because of the expansion, that counts as you as an employer, they are insured. So even though it's Medicaid, that counts as your employees having health insurance. If we don't have Medicaid expansion, those hourly wage employees, your insurance may be too expensive for them, and there's a certain calculation to determine. If they don't have access to Medicaid and your insurance as an employer is unaffordable, that employer is more likely to be subject to fines and penalties because of that. So those are really the 2 main reasons that the chambers, or we've seen a lot of the chambers around the state come out in favor of this. This is 2 links to that Channel 9 video that I talked about. The top link is about a 5-minute clip that is actually the interview with the guy from Salem Memorial District Hospital. The second one is actually the full show. It's 28 minutes long. You can watch it online, or we do have copies, yes. We have copies of the DVD on the table, and it's what's on the DVD is just the 28-minute show. So that is it. I would be happy at this point to open it up to questions, comments, discussion, whatever you are interested in talking about. Yes, ma'am.
When you were talking, you kept using the word new enrollees in this program. So what happens to the current enrollees in the Medicaid program? Does the bar get raised for them as far as care?
So the blue bars are that's current eligibility. So those are the existing enrollees. Not a whole lot changes for them. So the Medicaid program, according to the Affordable Care Act, stays pretty much the same. There are some things that states can choose to do for all Medicaid enrollees, such as health care homes, preventative care stuff, but it's not, for the most part, when I say new enrollees, I'm talking about the pink bars, the people that will be newly eligible for Medicaid. Now that basic set of benefit, that benchmark benefit plan, it's going to be very similar to what the people already in the program receive. It's not a huge change in new benefits. Yes, sir.
Are there any figures of available to explain how much money this state has lost by our legislators denying federal funds up to date?
Not that I know of. And are you talking like denying federal funds related to the Affordable Care Act?
Yeah, you had the 31 million that was scheduled to help them set up the programs, plus the Senate went around the state 2011 having hearings, and ultimately they didn't listen to what we asked them to do.
Right.
They didn't take advantage of the federal dollars there either.
Right. So what the question is referring to is there has been some federal dollars that have come down to Missouri that are just sitting there. And Missouri, the legislature refuses to accept those dollars and to spend them. What were they supposed to be spent on? So one of the major things is if you have this program where it's the exchange and Medicaid, and they are two different programs, and the top is private insurance and the bottom is Medicaid, what the ACA says is those two programs need to be able to communicate because you're going to have people going back and forth between Medicaid and private insurance. So one of the requirements was that states update their IT system for Medicaid. Why would Missouri need to update its IT system for Medicaid? Well, I will tell you that Medicaid's IT system is written in COBOL, which is a computer language from the 1980s that they don't even teach people anymore. They actually are at this point having trouble finding people to come fix the system when it breaks down because they have to pull people out of retirement to do it. So we got about $25 million to update our IT system, and the feds say you have to do this so that the two systems can communicate. And so far the legislature has not agreed to accept those funds, which means we're supposed to have that new IT system October 1. It's going to be a little dicey. And so what we're hearing from the feds is the ACA says if you go to the health insurance exchange and you apply and you fill out an application and it ends up that you're Medicaid eligible, that exchange can't say, oh, you're Medicaid eligible, go over there and apply. They have to say, you're Medicaid eligible and we're going to get you enrolled behind the scenes. You aren't even going to know. It's just going to be seamless. Well, it only works seamlessly if these systems can communicate. So what we're hearing from the feds is they're very frustrated. Missouri's not the only state that's dragging its feet. They are saying that if somebody enrolls in the exchange, they're Medicaid eligible. Currently, Missouri's IT system can't accept applications electronically. So the feds will print out a paper application for Medicaid and mail it to Missouri's Medicaid program. This is going to be a mess. So it's going to be really interesting, but that is what he is referring to. Yes, ma'am.
So the question that I get asked a lot by people is, I'm dually eligible. I have Medicaid and Medicare, and I have spend down, which restricts my access to health care. How are those people going to be affected?
Great question. So there is some misinformation out there, I think, around. Some people are saying that this expands Medicaid to everybody up to 133% of poverty, and that's why I was trying to clarify it really doesn't. So what the Affordable Care Act does is split Medicaid recipients into two categories, all these wonderful acronyms. But one of the categories is the MAGI population, and it's M-A-G-I, and it stands for Modified Adjusted Gross Income. That category is children, parents, pregnant women, and childless adults. And what it means is there will be no asset tests, they will just look at your adjusted gross income and determine if you're Medicaid eligible. It's supposed to simplify the system, so that is one way that impacts currently eligibles, is that it's supposed to be a very simplified way of determining eligibility. Unfortunately, the other category, very creatively, is called non-MAGI population, and it includes the elderly, blind, and disabled, which will still have income or asset tests. Things don't change a lot for that population right now. And Medicaid is not expanded for those populations, which means there is something, so let's say you're disabled and you have income and you're at 100% of poverty, you may be Medicare eligible, but if you want to be dual eligible and have Medicare and Medicaid, you have to spin down your income from 100% of poverty down to that 85%, and you have to do it on a monthly basis. So every month you start over and you collect your medical bills, and once you spin down to this level, you magically become Medicaid eligible, and maybe it's the 15th of the month, and then 15 days later you lose Medicaid eligibility and you have to start the spin down process again. It's really complicated for a lot of people. It doesn't encourage people to work, because why would you want to do that and go through this mess every month? But for now, that spin down program will still be there. Now, some of the benefits that are being touted by having a childless adult category, it takes quite a bit. A lot of people, something may happen to them, and then years pass, and then they then officially apply for disability and become disabled. But there's a lot of time in there sometimes for people. And there isn't a lot of health care for those people that they aren't qualified for disability yet, and they don't have kids, and so there's no category. So the thought is, if we create this childless adult category, we're actually going to be providing, hopefully, some care. So something may happen, maybe we can provide some rehab, some services, so that they never have to apply for disability. They can get their health care needs taken care of and then go back to work. So there's thought that this will actually increase a lot of services and keep people from moving into that disabled category, which is the most expensive category in Missouri Medicaid. It costs close to $16,000 per enrollee per month. It's a really expensive category. And partly it's because when you become disabled, it may take a few years, you apply for disability, you become disabled, you become disability eligible. Once you become disability eligible, you may be eligible for Medicaid, but then you have a 25-month wait before you're Medicare eligible. So we are letting people's whatever's happened to them progress for years and years and years before providing them with basic health care, which if we can change that and catch things really early, the argument is that it will really make a huge difference for those people. Yes, ma'am.
Will the expanded group also be held accountable to that spend down?
The what?
So that we're moving it up to 133% say the childless adults.
Mm-hmm.
They will not be subject to that same spend down front. Is that correct?
Right. There will not be spin down there is not spin down for the MAGI population. So kids, parents, pregnant women, or childless adults. No spin down. Spin down only is for the ABD population. Yes, sir.
Just give you some feedback. Senator Dempsey talked to the Chamber of Commerce for this area on the 1st, and he said that the Senate remains where they have been in their objection. They feel that the numbers are not going to, the federal government will change the percentage, and that even though he's sitting next to the representative from SSM and Chief Meat on him for the disproportionate share income, he's saying, yeah, we hear you, but we think that those numbers will be overwhelmed by the federal government changing the percentage on it, so we'll end up paying more.
So that was the argument, the third point of Congress can change the terms. Interestingly, for Republicans, their own Republicans across the nation have sort of shot that argument. So Governor Kasich in Ohio is a Republican governor, and there were similar concerns that Congress could change the deal of the arrangement. And so Governor Kasich, who hates the Affordable Care Act, hates Obamacare, has come out in favor of Medicaid expansion, and one of his solutions to that concern was put a kill switch in the bill. So if the state legislature passes Medicaid expansion, put a phrase in there that says, we'll expand Medicaid, but if Congress changes the deal, it's dead. We're going to kill it. So Governor Nixon has actually proposed the same thing. It's in his proposal. So that's sort of a dead argument, because there's a very easy fix to that of just put language in the bill that says, if Congress changes it, the Medicaid expansion goes away for us, which really holds Congress's feet to the fire to say, and I think a lot of states are going to end up doing that, which means if Congress changes the deal, a lot of states are going to pull out of this. Let me go in the back. Yes, ma'am. Yeah, in gray. Yeah.
Can you talk a little bit more about this designation of a person that's medically frail and how a person who's categorized as medically frail might qualify as a childless adult and under expansion as opposed to the 85% of federal poverty level for like the age one and the
So I have been studying Medicaid for 10 years in the state of Missouri. I knew I was somebody in these 8 Medicaid town halls was going to ask me about medically frail. My understanding of medically frail, and let me say I am not sure that I'm 100% right. My understanding of medically frail is that they are not eligible for disability, and so they aren't falling into that disabled category, but they have some sort of condition that really makes it, I don't know how they define it, but it is a population, it's about 17,000 people, so it must have pretty strict requirements.
Is the medically frail in the federal language, or do we get to define medically frail as we expand?
No, what we can do is just get rid of that category, because now somebody that isn't disability qualified that would fit under our medically frail program, they're going to fit either, if they have dependent children, they're going to fit into parents. If they don't have dependent children, they're going to fit into childless adults. Because the medically frail program does have a cap on the eligibility related to income. So all of those medically frail are going to fit into one of the 2 new categories that are created. So it's really just getting rid of the medically frail program and shifting those people to a different category, because they're not in the disabled category because they don't qualify for disability. And that's the best that I know, and I apologize.
Thank you for your
Yes. Yes, ma'am.
My understanding is that states can, even without a kill switch, pull out of expansion. Certainly during the 100% feds are paying. Does that extend forever into the future, or is there a time limit at which point the feds say, no, now you're locked in?
No, that's forever. So Medicaid's been around since 1965, and states have a lot of control over their programs. So we changed, parent eligibility used to be, in 2005, it was 85% of poverty, and we cut that back to the minimum of 18%. So you actually don't need to put a kill switch in the bill. You can change Medicaid eligibility anytime you want. Now, if you want that enhanced match rate, so one of the discussions going on in Jeff City right now is that there is a bill that was filed by a Republican, Representative Barnes, and it expands Medicaid for these 2 groups, but it only expands them up to 100% of poverty. And the reason he did that was his sort of reasoning was, well, we don't need that overlap. We can just go up to 100% and then the problem is that so far the administration and HHS at the federal level has said that doesn't count as an expansion. It counts as it's a partial expansion. You can do it as a state, but the match rate that you get if you only expand up to 100% is going to be the normal 60-40 match rate, that you actually have to expand up to the 133 to get the enhanced match. So that is holding states. They can't, let's say 10 years from now, scale back to 100 or 90% because they're going to lose that 90-10 match rate. But they can change their Medicaid programs at any time within the federal sort of rules that exist. So you don't need the kill switch. A lot of states are putting the kill switch in because, as we saw in 2005, to change Medicaid is a battle. There's a lot of advocates that fight really hard. And so putting in a kill switch now makes it a lot easier to sort of say Medicaid expansion gone and you don't have to have a big political fight about it. That's why we're seeing it get put in. But they could do it without the kill switch. Yes, ma'am.
What other, you mentioned the is used to fund the Affordable Care Act. So are there other special populations like that that could get affected, and how so?
That is a really great question. And once again, so we're all sort of still trying to figure this all out. And I've had a conversation with a couple of the AIDS organizations in St. Louis about this exact topic. Yes, there are. Ryan White is one of those programs where I think some money will be reduced from that to help pay for the ACA. And some of the rationale was that with expanded Medicaid, with exchange, where you can't hold people, you can't base insurance rates on pre-existing conditions, that people that are HIV positive will be able to access affordable health insurance, and so they're taking away some of the money from programs like that. So that's an example. I'm sure there's other programs that are losing dollars like that. I don't know them offhand, but it's something that we have been looking into to try to figure out. With all of this fiscal cliff and sequestration stuff, it's really hard to figure out changes that are due to ACA versus changes that are due to other stuff the feds are doing. But it's something a lot of organizations need to be paying attention to because A lot of these, when Congress was doing this, they said, we don't need these pots of money because people are going to be covered in different ways. And then the Supreme Court ruling around Medicaid specifically really sort of has put us in a position where maybe not. Like maybe some of those populations won't have insurance and we just cut funding for those programs that care for them. So it's a huge concern. Yes, sir.
Is there anything in the Affordable Care Act that lowers or does away with any parts of veterans' benefits? And the reason I'm asking the question is I travel a lot out in rural communities, and the veterans organizations there are under the impression that it's going to undermine their benefits.
I have read the law. It's been a while. There is nothing that I know of that affects veterans' benefits. There's nothing that cuts benefits or cuts services to veterans. There may be some stuff in there about the Veterans Administration and trying to make it run more efficiently or changing some standards, but there's no direct cuts to benefits or services for veterans at all.
So if I would find a VFW or Veterans of Foreign Wars group and they said, well, have the guy come down and talk, would you volunteer?
I would come down and talk. Yes.
Thank you.
Any other questions? Yes, ma'am.
I have one about the penalty for those who can't afford insurance. What happens if a person is not of an income level to even be able to afford the fine?
Great.
Or the tax penalty, what happens?
Great question. So, two answers to your question. One, after the Supreme Court ruled and said that this yellow box Medicaid expansion was optional, the Department of Health and Human Services issued a memo just a couple months ago that clarified that they said because the Medicaid expansion is now optional, any individual that happens to be in a state that doesn't expand Medicaid that would have fallen into that solid yellow area will not be subject to the penalty under the individual mandate. So they will not be fined because they don't have an option for health insurance. The other thing in the individual mandate that was there, that's in the law, that's been there since the beginning, that a lot of people don't know about, is there are some exemptions to the individual mandate. So there are some groups that can be exempted from paying that fine. One of them that they put in there, interestingly, was financial hardship, which was interesting that it was in there because it was like, why does that need to be in there? People will be Medicaid eligible. Now it's sort of good that it's in there. One of the other categories is religious exemptions. So, and I always get this wrong, but I think that it is like religious faiths that truly, like it's in their faith doctrine that they don't believe in organized health insurance. And I think it's the Amish is an example of that. But so you can't just say, hey, I'm Catholic, I don't believe in health insurance, and not pay the fine. It has to be part of your faith doctrine. And then there is a rule about 8%. It's called the 8% rule. And what that says is if you cannot find health insurance that costs less than 8% of your family's income, then you can get exempted from the individual mandate. So there are some exemptions to that mandate that a lot of people didn't know were there. And it really is to protect people that can't find affordable insurance or don't have any insurance options. Yes, sir.
Can you describe in any way, briefly, what is considered to be a minimum amount of coverage that would say that one is covered?
Yes. So there is, and I think regulations came out on this recently, and I've been traveling and haven't read them. So pretty much one of the things the Affordable Care Act does is set a standard, and it says this is what a qualified health plan is. This is what it has to cover in order to be a qualified health plan. And what they've done is sort of group services into 10 categories. So it's things like outpatient care, ER, mental health and substance abuse, prescription drugs, maternity care. So there's like 10 categories, and it's called essential health benefits. And those are the things that have to be covered. So I can send you a full list if you want to grab my business card, but there is sort of a list of services that have to be in there. There is some talk that, and some people, there's sort of two sides to most issues. The administration, obviously sort of through the Affordable Care Act really doesn't like and is trying to phase out things like high deductible healthcare plans with health savings accounts. And there's a lot of pushback on that, and I'll give you the rationale, whether you agree with it or not. The rationale for sort of phasing out these high deductible plans, there's a limit on what is high deductible. Like you're not going to be able to have a deductible more than $2,500. The rationale for limiting that is high deductible healthcare plans work really well with an HSA if you can afford to put money into the HSA or your employer puts money into that health savings account. The problem that we're seeing in hospitals, many hospitals are speaking to this, is that a lot of people who are buying high deductible plans are buying them because they're affordable, and then they're not putting any money into an HSA, and then they go to the hospital. And what happens is they go to the hospital and they have a $10,000 deductible and they can't pay any of it, and then the hospital's sort of left holding the bag saying, well, you had this high deductible plan and you didn't have any money to pay the deductible. So they got a lot of pressure from hospitals, I think, to sort of crack down on high deductible plans, but there is that requirement. We still have them, but the deductible is limited pretty significantly. Yes, sir, in the back.
With regard to that DSH, is there any way that an individual, or let's put it this way, are hospitals, any given hospital, are they obliged to reveal what that amount is on any basis that they have to claim?
I don't know if, I would think that it's federal dollars coming through. I would think it's public information somewhere. I have never seen hospital by hospital, but as I've been traveling doing these presentations, I've had many hospitals at, like somebody from a hospital, and they've openly in the meeting told us how much their dish funds were. So like in Hannibal, the hospital up there said that they get about 1.1 million a year in dish funds. So it must be, I would think the hospital association would have that. Do you have an answer for me?
Well, I have an answer for the two hospitals, SSM, because the lady at the Chamber of Commerce meeting said that they would lose the main hospital at St. Charles $65 million, and the subsidiary hospital they would lose $25 million.
Okay. So the numbers are out there. I think the best place for that information is probably the Missouri Hospital Association. I know they're looking at this issue. Part of the issue with the dish funding cuts is the ACA sort of lays out a general formula for how these cuts should be made, but we're waiting. So with any law, when you pass a law, that's just step one, and then all these regulations come out. How do you implement that law? And when we're done, I mean, people think the Affordable Care Act was huge at 2,500 pages. When we're done implementing it and we have all the regulations out, we're talking about tens of thousands of pages of regulations. And we don't yet know exactly what formula they're going to use to cut dish. We know in general that for the Medicare dish funds, it's an initial 75% cut for those dish funds, and then they're going to add some back depending on how much uninsured you have. But it's, yeah, so we're still waiting to sort of see how are they going to determine this. Yes, sir.
The reason why I asked the question, it seems that is a simple and probably way too simple means for a person to understand the people who go to the emergency room.
Right.
It's always talked about, but I never see numbers, and that's why.
Yeah. So yeah, and it's how much uninsured care do we provide, and where does that money? How much has cost shifted to private insurance? How much comes from dish funds? How much do hospitals just write off as charity care and bad debt? And the Hospital Association puts out an annual report that looks at charity care. So how much are hospitals just writing off? And we passed the $1 billion mark in Missouri. The Missouri hospitals in 2012 wrote off $1 billion worth of health care for the uninsured.
Yeah, but was that real cost, or was that,
You know, it's the Hospital Association, so that is probably what they would charge. So you have their costs, which you're right, like a $10 aspirin. That is probably the cost of those services for a person who was uninsured that walked in, which for the uninsured, it's actually the full cost. And then if you have insurance, it's a lower cost, which doesn't make a ton of sense, but it is the higher cost, so you are correct. It's probably a little, well, maybe a lot inflated. It's still gonna be a lot of money, but yes.
very hard to get the answer to. When did the DSH begin? When was that made into a law? How long has it been around that hospitals have been unable to turn away patients?
So that's a great question, and I do not know the year offhand because the law that came into effect, so DSH doesn't require hospitals to see uninsured. It's actually a law, it's called EMTALA, E-M-T-A-L-A, and it stands for something. But it's when that law came into effect that said hospitals can't turn away uninsured patients, and then at some point after that, they started doing the DSH funds to help them pay for the uninsured patients. Do you know? Does somebody raise their hand? Do you know the year?
I can tell you why.
Why they did
Died on the steps of a hospital,
Right.
and it was approximately 1938.
So I think it's been around for a while.
And after that, they had a hue and cry throughout the United States, at the number of states at the time, and they enacted this law that says if you make it to the emergency room, they have to administer coverage.
Right.
And what has happened with that is some of the opposition to the Affordable Care Act says that it's mandated that we have to take care of it. And that law came in about 1938, and it was because somebody died outside the hospital, and they wouldn't let him in.
Right.
And if
So
you
it
repeal
sounds
that-
like it's been around for a while.
If we repeal that, then we could all just go out and support one
There
and
you
die.
go. Is there another? Yes, sir.
Maybe this is more of a comment along the same line. Some people say, well, we don't need to have any kind of health insurance coverage for everybody because when people go to the hospital, they have to be treated. But I don't know that that means that someone is diagnosed with early stages of cancer, that the hospital is going to treat them, give them all the chemotherapy and radiation, and they're just going to die.
So 2 points to that. So yeah, I mean, hospitals have to see you, but if you go in and happen to be diagnosed with cancer, that doesn't mean that they have to provide all those services. You may be able to find a program out in the community to help you. The other point that and I've heard this around, well, you can go to the emergency room and you can get care. Like I said at the beginning, the United States spends $8,000 per person on health care, and it's double the next closest country. Part of the reason is because the ER is the last place you want to receive health care unless you are in the midst of a health care crisis. It is not the place to receive primary care. Not only do you just not want to receive primary care there, it's the most expensive place to receive care. So we have a system that is focused on treatment, and part of what the Affordable Care Act does try to do is shift that to more of prevention and wellness. If we can actually provide primary care, preventative services, and people have the insurance to access that type of care, it's not even in this presentation because nobody's done the research to estimate because it's tough. But if people actually can access primary care and we keep people out of the ERs for things they don't need to be there for, or we catch things early and can manage them, how much savings does that create? And so that is not quantified, but it is something that some people are talking about. Yes, ma'am.
One problem with what you just said is that it is getting more and more difficult to even get primary care. And there was an article in the paper just the other day about the fact that there aren't enough doctors, primary care doctors, and when this ACA goes into effect, it's going to put a lot more people in the system, and it's going to be a lot harder for everybody to get medical care.
So it's a great point, and it's exactly true. We do have provider shortages in this country, primary care docs, we have a nursing shortage. The Affordable Care Act did see that and recognize it and try to address it in some ways. So part of the things that if I had 8 hours, I could tell you all about the Affordable Care Act. There are new delivery system models, and there's a lot of those focused on primary care. So we are not going to have enough providers, primary care doctors. We're not going to have enough nurses, but we know we're going to have a lot of people retiring, baby boomers getting Medicare. If we expand Medicaid and we have all these new people with insurance, what are they going to do for primary care? So there's these new models of care such as medical homes where it is not just a primary care doc, it's a primary care doc, a nurse practitioner, a physician assistant, a dietitian, a nutritionist, a social worker. you go to the doctor, you may only get to see your doctor for 2 minutes, but you may be there for 45 because you get to meet with the right person. Maybe you have diabetes and you should really be talking to that nurse practitioner about how to manage your diabetes. So there is some effort to expand the scope and type of health professional and their work in primary care, because that is a huge issue and a huge concern, and you're exactly right. And we're not going to magically expand the number of primary care docs overnight. And so they're trying to address it in other ways, but it is a legitimate, huge concern of where are we going to get all this primary care? I have a staff member raising her hand, which, yes, ma'am.
It's not a question.
Oh. I was like, don't question your boss.
It was established in 1981.
Oh, thank you. DISH was established in 1981?
DISH funding system was established in 1981.
Great. Thank you for that. So it is 8:30, and I want to respect that we said we would go from 7 to 8:30. So thank you all for coming tonight, and I will stick around if people have more questions.